funding is composed of out-of-pocket expenses that people make on their own to cover their healthcare costs. Health insurance, whether it's the public health insurance offered by the various governments, or it's the private offered by the HMOs. And then there are the various investors. Sometimes the investors are venture capitalists, sometimes they're angel investors, and sometimes the investors are the various overseas development assistance in health that a lot of countries in the global south get. They are the medical devices. These are the devices, most of them these days are worn on the body. So these are the ones that measure your blood pressure, heart rate, insulin level. They're the imaging devices like X-rays, like CT scans. And there's telehealth and telemedicine. This is essentially just leveraging ICTs to deliver health services remotely, thus addressing the barrier of distance to access of service. There are the social networks, which with the penetration of social media and technology across the continent of Africa are really, really starting to become very important. So this is leveraging social networks and network tools to promote health and wellness. Recently, a researcher from the University of Zurich conducted a research into the use of WhatsApp and Facebook by nurses and nursing assistants in Ibadan and around Ibadan to promote wellness and better health practices amongst patients. Of course, there's big data and artificial intelligence, that inexplainable black box that we all hope will pay so much dividend, but so very few of us seem to understand. And this is just essentially leveraging the large amount of data that's collected in the health sector to inform the decisions we make in the health sector and to direct how we do things. There's medical and health information, and this refers to such things as medical records, health records, decision support tools, or even disease surveillance tools. Just any sort of technology that involves the collection, processing, managing, or sharing of information from the health sector. And then finally, there's standards and interoperability. Standards and interoperability, more often than not, is thought of as a core technology or technical term, but it is one of the founding principles of being able to use digital technologies efficiently in healthcare. So standards and interoperability essentially facilitate the efficient and optimal communication between technology devices. Ideally, this should be possible independent of whatever technology or whatever vendor you're using. It's standards and interoperability that make it possible for a pediatrician in Lagos to send an X-ray that he or she has taken of a child's arm to a specialist in Jakarta or to a consultant in Washington, DC for a second opinion. It's standards and interoperability that make it possible for us to share health records, for us to share health information either across geographies or sometimes across organizations. So we've talked about all the wonderful and nice opportunities of digital technologies in health, but these are not without some, unfortunately, challenges. A major challenge is the governance and regulatory landscape in which we operate. I know a number of people would say, let's be careful not to over-regulate. Let's be careful so regulation does not stifle innovation and growth. And that is true. But in the absence of governance, in the absence of regulation, in the absence of guidelines, or in some cases, legislation and compliance mechanisms, what we have is some sort of anarchy. In the absence of governance, we will not have a proper enabling environment. In the absence of an enabling environment, a lot of investors will not be comfortable. A lot of players would easily either get muzzled out or get ripped off simply because they just don't know, or simply because there are loopholes. And indeed, this is not just specific to Nigeria or any one country. Across most of the continent, my experience is that the governance and regulatory landscape for the use of digital technologies in health can do with some shakeup. Funding is also a major issue. More often than not, in most countries, health is not considered a priority. Yes, in spite of all the major promises and major commitments, more often than not, the health sector in most countries across the continent is still underfunded. Now, within that underfunded slice, it's going to be a bit more difficult to carve out a little slice to cover your digital technologies. And so funding is a major challenge, whether it's funding from the government, funding from the private sector, foreign direct investment, or even development investment. Infrastructure, that, as most people would agree, is one of our biggest challenges on the continent. Excuse me. A lot of what you will do with digital technologies in health relies on infrastructure that is challenged across most of the continent. Either it is power or internet connectivity, or in some places, it's just the infrastructural pieces to put in place a support system. Capacity building is another challenge. There is not a lot of structure around capacity building done across the continent, specifically targeted at building digital health capacity. It's one thing to be a computer expert. It's a completely different thing to be a health expert. It's yet a third different thing to be a digital health expert. Now, do we want to suddenly make all the players in the health sector technology experts? Or do we want to make all the players in the technology sector health experts? Across most of the continent, there is still not yet a firm commitment or a firm plan to create that cadre of workers whose specialty is digital health. Once again, standards and interoperability is a major challenge. Because we don't have clearly established standards, we're not able to achieve interoperability. Because we're not able to achieve interoperability, a lot of the gains that digital technologies offer the health system are not achieved. So without clear-cut standards for interoperability for health exchange, State A or Region A could collect a lot of data on malaria in a silo. State A could also collect a lot of data and information on tuberculosis in yet another silo, and do the same thing in HIV/AIDS, a third silo. But State A could also be getting funding from the global funds to fight malaria, tuberculosis, and HIV/AIDS. But because the standards for information collection, information exchange do not exist, it becomes difficult to cross-reference or correlate information from these three siloed programs. And so it's not impossible that you are making malaria program plans and decisions independent of tuberculosis. You're making the same decisions for tuberculosis independent of HIV/AIDS. When we begin to address the issues of standards and interoperability, we'll be able to better interconnect and inter-exchange our information, and the huge amount of data that digital technologies help us gather will become more useful. Our final challenge is human capacity. Yes, human capacity. There are a lot of people in the health sector. There are a lot of people in the technology sector, but there are not a lot of people in any of those sectors that have adequate knowledge or understanding of the other. So if you look at the average hospital, there are a lot of nurses, pharmacists, doctors, health records officers, and stuff. Try to deploy an electronic system, say an electronic medical record system. Part of the largest challenge you would face would be the training, because it's not impossible that a number of people, particularly, no offense to anybody, the older staff have not at any time encountered digital technologies. Try to get a technology specialist or try to get a database engineer to build an electronic medical record system from scratch. Chances are, though he has developed all kinds of systems for hotels, for accounting, for banks, he has very little understanding, or she has very little understanding of the health sector, of the unique nuances of the health sector. We need to, like I said earlier, start to engage in a series of focused activity to build human capacity in the health sector to be able to better use digital technologies. So let's just look at some COVID-19 specific opportunities for digital health. And there are a lot of this. Again, this is not exclusive. So one of the very popular ones, disease surveillance. Digital technologies have been used for as long as I can think of. They continue to be used for disease surveillance, for monitoring, and all kinds of stuff that are related to response to the COVID-19 pandemic. Digital technologies are being used to monitor quarantine and self-isolation, sometimes using the data from the phone of the people being quarantined. Sometimes they're actually giving armbands, electronic armbands that can be monitored. Digital technologies are used for health messaging, whether it's messaging around wellness, messaging around health practices, messaging around safe practices, wash your hands, wear a mask, keep a distance. But then, more importantly, digital technologies are being used to fight something that's called the infodemic. So the infodemic is described as the slew of information, not always verified, that comes with epidemics and pandemics. And sometimes they are more dangerous than the pandemic itself, because a number of people take this information, take this unverified information, and they actually use it to inform decision. I remember a few years back when Nigeria had the Ebola crisis, there were people who were drinking salt. There were people who were having baths with salted warm water because the information had spread. Digital technologies are also being used in the response to the COVID-19 pandemic for planning and management of the response. So if you think about it, there's a large number of moving parts that constitute the response to COVID-19. So there are the logistics parts, there's the HR component, there's funding, there's client management, there's all kinds of stuff. And more, digital technologies that were not necessarily designed for the health sector are being used for the planning and management of that response. As expected, telehealth and telemedicine has really exploded across most of the continent, actually across most of the world, since the occurrence of the pandemic. I think a country in Southeast Asia pushed through guidelines for telehealth and telemedicine in a very short time because the health sector needed to have in place some sort of guidance, some sort of regulation, so that care providers, clients, and patients will be comfortable to leverage ICTs and digital technology where possible for people to be able to access care. Digital technologies are being used for clinical management of patients. A number of systems and a number of devices exist that help the clinical management of patients, particularly patients who are infected with such a disease like COVID-19, where it allows for some level of remote or step back management. Digital technologies are playing a very, very big role in the research to develop a vaccine, either in simulating or in modeling the response of the disease to the various vaccine candidates. Online communities is another way, quite innovative way in which digital technologies are being used in the response to COVID-19. So because a number of us cannot gather together, because we are not able to go off to meetings, conferences like we used to, a number of these meetings have moved online. There are several meetings I've held with colleagues within Nigeria and across the world where we would normally have gathered in person, and we're doing a lot of it online. I have attended and been privileged to speak at about 3 or 4 conferences or events in the last 2-3 months, where ideally would have flown into whatever city was being held in, stayed in a hotel, gone to the venue, yada, yada, yada. But a lot of this I've done from home because we're leveraging digital technologies. Artificial intelligence is another wonderful opportunity that's been leveraged in the response to COVID-19. So artificial intelligence is playing a big part in the track and trace, in the modeling, in the development or production of the R number, so governments and institutions are able to advise and come up with the response. Like I'd mentioned, digital technologies are being used for the track and trace, and digital technologies are also playing a big role in screening for the infection. Now, let us look at those 3 digital technologies I said we'd look at. Remember, I said we'd look at electronic medical records, telehealth, and artificial intelligence. Now, at the most basic, electronic medical records are essentially the digital versions of the medical records that we used to keep on paper. Now, putting this in electronic format comes with a lot of value and a lot of advantages. We have the potential to greatly improve the efficiencies of the health system. We have the potential to optimize and better support several aspects of the clinical care. But it's not all so rosy. There are a few risks, a few cons. So for each of the technologies I'm going to talk about, what's in the green box are all the nices, all the good bits that we'll enjoy. And what's in the red box are some of the pitfalls we should be wary of and some of the cons that may create problem with implementing. So as expected, the pros with electronic medical records includes less paperwork, easy electronic access to medical records, greater coordination, reduced errors. We don't have the challenge of, doctor, what did you write? Improved data management, data mining capability and research. It's going to be a lot easier to conduct research on anything if I can have access to all the anonymized medical records in a particular facility, rather than someone opens a massive room and says, these are all the files, knock yourself out. Decision support is also a lot better because I'm able to pull up history, I'm able to compare case notes. Portability is greatly eased. When medical records were on paper and you needed to move your records from one hospital to the other, what used to happen was you would get a copy of your records after a lot of discussion and storytelling in a sealed envelope. If they give it to you, more often than not, hospitals insist that they would send it to the other hospital independent of the patient. Now that comes with all kinds of risk. There's the chain of possession. What happens if it gets lost and stuff like that? But with electronic medical records, portability is greatly eased. It's as good as sending an email. Finally, administrative reporting and monitoring is a lot better. But then there are the cons. A big con is the initial investment, either in your software, in your hardware, or in training, like I mentioned earlier. More often than not, electronic medical records are successful in deployment if there's a champion or champions. And that on its own is a risk. You'll run the key man risk. That is the risk of having one person who is key to everything. You take away that person and sometimes everything falls apart. Another risk is the risk of a weak not always, but a weak business case or planning. So more often than not, in my experience, when electronic medical records are being deployed, a lot of emphasis is paid to costs. A lot of emphasis is paid to the value it will add, to doing the training, to doing that, to doing the data entry, doing whatever. But I find out when they start running into problems that more often than not, very little time and effort was involved in the planning. So like anything we do with technology, generally, but specifically with technology, we should start with some serious planning and a business case that justifies why do we want this electronic medical record? What do we expect it to give us in terms of value? What are the costs? We weigh all of this and decide, is it worth the risk? Another risk is user inclusion. There are very few occasions where electronic medical records are developed, designed, or even deployed with the active participation of the main users. So what I see more often than not is the head of the hospital nominates somebody. More often than not, if it's a large hospital, the head of their IT team, or someone who acts as their ad hoc IT support guy. He becomes the project manager or the interface with whoever is deploying the electronic medical record system. More often than not, the core users, the nurses, the doctors, pharmacists, the medical record staff are not involved. That's a major risk, and that's a cost, a major possible cost of a failure. Recurrent cost is another con. So there's the recurrent cost around licensing, around support, and around upgrades. Then there's the issue of the transition friction or the change management. It's essentially the conflicts that come when staff or human beings are just generally not keen on adopting something new, be it technology or new processes. That on its own can be a major cause for failure. Data migration and entry is another issue. So imagine a hospital has been existing for 10 years, and lo and behold, medical director has a flash and acquires an electronic medical record system. And that is deployed beautifully. Everybody is happy. But then we have a big problem. There's 10 years of medical records that exist on paper. The question is, do they continue to run paper parallel to the electronic system, or do they migrate everything from paper into the electronic system? Or worst case scenario, do they junk everything in the paper and just start afresh with the electronic system? Obviously, the second option gives you the best output. Migrate all your paper records into the electronic system. That can be quite daunting. And I've seen 1 or 2 deployments of EMRs fail simply because of the massive amount of work involved in the data entry. Finally, and possibly sometimes, the biggest challenge after the initial investment, infrastructure. It's difficult to run an electronic medical record system if the facility hasn't got good power for a good part of the day. Now, this power could be off the grid, national, regional, or local. It could be alternative power, generator, solar, inverter, or whatever. But even after you address your power challenge, then there is the challenge of connectivity. Of all the things your electronic medical record can do, there are some things it cannot do for you without having internet access. On the continent, internet access is still a bit expensive. Let's look at another technology. So let's look at telehealth. This is trending with a lot of people these days. This is of interest to a number of us, essentially because with the COVID-19 pandemic, more and more people are uncomfortable going into health facilities. Health facilities are trying to keep themselves and their patients as safe as possible. So telehealth is of interest. Telehealth is essentially just delivering healthcare services where the patient and the provider are separated by distance, and you do this leveraging ICTs. Now, this you could do in a number of ways. It could be a phone call, it could be a video call, it could be a teleconsult. Sometimes there are robotic consults that happen virtually. Now, the advantages or the pros of telehealth is it reduces the limitation of geography and distance. So somebody who lives in Ekpetedo or who lives in Lekki can have access to the best medical care in the world, irrespective of where that care provider is, by leveraging telehealth. It doesn't matter where you are able to, once the technology and the infrastructure exists. I'm sure everybody at one time or the other has made a call to a friend who is a medical doctor and said, hey, Shegun, how are you? I'm having this rather funny headache. My eyes are aching, my nose is running. What do you advise? So imagine doing that on a structured and larger scale. Imagine doing that and being able to support it, for example, with video calls. And the technology exists. It exists and is currently being used and deployed in Nigeria and across most of Africa. So that's one pro of telehealth. It will reduce the limitation of geography and distance. It can reduce costs to the patient and the provider. There are some setup costs, but once it's up and running, it can reduce cost, particularly in cases where patients have to travel large, really large distances to access quality care. It can lower the risk of new infections. So, like I said earlier, a major challenge with the COVID-19 pandemic is hospitals have no guarantee, that the patients coming in don't have the coronavirus. Neither do the patients have any guarantee that they cannot catch the coronavirus at the hospital. It's not just around coronavirus. There are a couple of other things, cross-infection, that can happen when patients go into hospitals, depending on what they're there for and where the hospital is. So telehealth would help reduce that. Telehealth would also provide some serious efficiencies of time. So people having to take time off work or wait at their service delivery point, waiting for the doctor or the nurse, a lot of that can be lowered because since the technology allows you to have a teleconsult or have an engagement with your care provider wherever you are, you can schedule it for what works for you. So you can schedule a call with your doctor during your break and have a quick discussion about your blood pressure measurement, about your insulin levels, where you would normally have had to go into the hospital, wait online, check in, yada, 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 and then come back to work. It also addresses the inconveniences of accessing healthcare. It can help reduce cancellations and no-shows. And follow-up care is easier, since follow-up care is a call, video or voice away, as you would have done for the initial bill. Most importantly, it offers greater access to specialized care to everybody. And this is the one, one bit where telehealth can actually seriously help the achievement of universal health coverage, because it improves the access of patients to quality, cost-effective health services, irrespective of where they are. But like I said earlier, it's not all so rosy. There are a few challenges, a few risks, a few cons. Major one is communication costs. So who's bearing the communication cost? If I engage in a telehealth consult via a voice call in Nigeria with my primary care provider, and the call lasts for 30 minutes, who's paying for that call? Depending on where the care provider is and how long the call is, the cost of such calls, of several such calls, may begin to add up, and I may have to consider, Isn't it cheaper to just go to the hospital with a good book, sit down and wait? There are also the issue of limitations in patient assessments. There's only so much you can do via telehealth. There are some assessments that necessitate physical contact. And while that cannot be escaped, everyone that doesn't need that can then be done using telehealth. So that's a limitation. Again, there's adoption and change management. It's possible patients and some care providers are just not comfortable talking to someone on the phone. I've heard a number of people say things like, I want to see the doctor that's talking to me. No, I'm not comfortable taking somebody else's assessment of, oh, her temperature is high, oh, her heartbeat is rapid. I would like to check on my own. So that's a challenge, the change management. Once we're able to address the adoption and the change management bit, it would make it easier to then swing back to the technology folks and have them develop the necessary technology that will make us more comfortable. Again, the regulatory environment. In a number of countries across the continent, there's not clear-cut regulation that encourages, supports, or outright outlaws telehealth and telemedicine. So it's pretty much a gray area, which means people who are skeptical and uncomfortable have no incentive to adopt. People who are enthusiastic and early adopters are not sure the limitation of their liability or how much cover they have. Another challenge is the issue of generational differences. This is closely tied to adoption and change management. You would find that a number of the younger generation would find it easier to adopt telehealth as a way of accessing healthcare because they spend so much time, there's so much that's being done online, they're pretty comfortable, there's a lot of trust for what happens electronically for them. A number of older people who had no introduction to technology until a bit later in life than the younger ones may have some challenges. Same way, I know a number of much older people who still till date refuse to use internet banking. I've heard people say stuff like, no, I want to see the guy who's counting my money. I want to count my money. I don't believe in all this electronic transfer. Then there's the issue of patient data security. This is tied to the regulatory environment. A clear-cut regulatory environment and an unambiguous regulatory landscape would help address issues around the security of the patient data. Now, we, to a large extent, are familiar with the security considerations for accessing healthcare within the facility. If I'm accessing healthcare remotely, who is liable? The carrier, whose network I'm using, the clinician or care provider who is dealing with me, or is the onus on me to establish that our connection is secure? Two big challenges. Internet access may be required depending on what kind of facility or technology is being used for telehealth. Smart devices may also be required. The third and final digital technology I'd like for us to just look at today is artificial intelligence. I chose this particularly because artificial intelligence and big data is the new rave, is the new magic dust that everybody seems to treat like, sprinkle it on the problem and it will just vanish. But artificial intelligence has been around for quite a while. The phrase was first coined in 1956. That's a number of years ago. And it essentially just refers to a machine or a system, computer system in this case, that can perform tasks that would traditionally be associated with human intellect. So more often than not, these include things like interpreting the meaning of speech. So when you pick up your iPhone and say, Siri, dial HLA, problem solving, and generally relying on large amounts of data. And that is where the technology is most useful. relying on large amounts of data to learn and to make decisions. So more often than not, the algorithms used for artificial intelligence, more often than not, they are trained in decision-making based on a set of tools and a set of data tied to a certain scenario. And the principle is you train the system so the machine learns, if I do 1, 2, 3 in this way, under this circumstance, I will get this. If I do 1, 2, 3 in this way, under this circumstance, but with a slight change, I will get something else. Now, with enough iterations of that, in principle, the machine learns, this is the desired output, this is how it should be treated, this is the circumstance that will work, and in this way. And that's artificial intelligence. Now, one of the advantages of using artificial intelligence in healthcare is, to a large extent, it can reduce errors. Because like I said earlier, it's able to use a large amount of data. So artificial intelligence algorithms are used for identifying skin cancer patients by taking pictures. So it's pictures and images of the skin of skin cancer patients, the skin of patients who don't have skin cancer. Millions and millions of these photographs are taken and run through the machine. And the algorithm learns how to read this, either read this for color frequency, read this for depth, read this for shape or image size or whatever. And the machine is also taught this particular image leads to this. This leads to this. So after that training is done, in principle, the idea is when you take the same sort of image from a patient you're not sure of, and you run it through the algorithm is able to compare the patient's image with the millions it had run before and say, based on what I've learned before, this is this. That's what it is in principle. Artificial intelligence can reduce errors. It can produce some very serious decision support because it's able to process information much faster. Data processing obviously is a big advantage. It is always available. Systems, computers don't necessarily need to shut down or close at the end of the day like human beings do. So there are some AI algorithms that you can use for triaging. I'm sure everybody is familiar with the phone app for just checking the COVID-19 symptoms. Have you traveled in the last 14 days? Yes. Have you been exposed to somebody who has COVID-19? No. Are you coughing? And you give a series of answers. And based on those answers, the app, the website, or whatever it is, tells you you are relatively safe, or, oh, you may have been exposed to COVID-19, please take a test. Now, for the ones that run off an app on your phone or run off the internet, they're always available, 24/7. They're not like the nurse or the doctor or the CHU at your local health facility who has to go home. Artificial intelligence also gives us the opportunity to create personalized and precision medicine. Personalized and precision medicine in that artificial intelligence allows us to use a huge amount of data, some of it medical, some of it non-medical, to inform and devise specific treatment for patients. So for example, for somebody who has high blood pressure, and the doctor applies whatever is the normal treatment, drugs, advices, exercise, lifestyle change, and all that. Having some more information about that patient's lifestyle, that is not necessarily medical. For example, how many hours a day do you work? How much sleep do you get? How much coffee do you drink? How much alcohol do you drink? Irrespective of what the patient says. Imagine if it was possible to link the patient's medical record to the patient's purchasing records from, say, credit card or debit card. So you're able to see how many cups of coffee, how many times or how many cups of coffee, how many times a week that coffee is had, how many bottles of beer, how many glasses of wine, how much exercise, how regularly is this patient paying for, say, the gym subscription. You cross-reference that with the gym access card. You cross-reference that kind of information with the information from the patient's fitness band. You're able to get a clearer picture of that patient's lifestyle, and that's unique. So you are able to personalize the treatment, personalize the medical support you give, and AI makes that possible. Also, AI helps with improved diagnostics and interventions. So depending on what has been programmed or what has been trained into the algorithm, there are AI algorithms that interface with a couple of these very high-tech fitness bands that can advise and say, your resting heart rate is XYZ, is above a threshold, please calm down. Or in some cases, your resting heart rate is so erratic, I'm going to send an emergency alert to the emergency service or to your doctor or to whoever you designate. Like I said earlier, it's not subject to needing to rest. So obviously there's no issue of burnout or overwork. AI in the healthcare space can help us improve anti-fraud activities, particularly around health insurance. You'll be amazed how much money is lost to fraud in the health space. AI can help with reducing that. And AI can generally help with improving public health. So AI can take health data, hopefully anonymized health data for the entire population of a specific zone or region. And on the basis of that, can begin to come up with models of this is a problem, this should be addressed, this can be done. So that's all the good stuff about AI. But there are some issues. The major one is AI explainability. Now, explainability in artificial intelligence refers to understanding the how and the why the algorithm makes whatever decision it makes or produces whatever outcome it does. Unfortunately, more often than not, AI is referred to and considered and perceived as a black box. A black box where not a lot of people understand the why or the how, but then sometimes are being asked to accept the outcome. So the explainability issue is a major issue with the use of AI. There are a number of ethical, legal, and social concerns around artificial intelligence. Now, I was talking earlier about artificial intelligence helping with medical imaging to detect skin cancers. Recently, a chap in, I think it's University of Oxford in the UK, came up with a theory, which I think is currently testing, I haven't heard of the result, that most of the images that were used to train the algorithm for checking skin cancers were images of people of Caucasian origin. So the skin is lighter. The way a skin cancer, the way an image of someone's skin with skin cancer will come up is completely different from the way it will come up for a lighter person than from a darker person. And these are ethical issues. There are facial recognition algorithms that have been proven to have issues because sometimes it's been programmed with existing bias. There's more often than not, if you program an AI algorithm, it would associate a certain gender with a certain profession and the other gender with another profession. While that may happen a lot, that does not necessarily mean it's so. So imagine a situation where an AI algorithm automatically, when you put in homemaker, it assumes it must be a she. There are a number of homemakers who are his, or you say maths professor, and the algorithm automatically associates it with a he, or you say CEO. So there are all kinds of ethical, legal, and social concerns. And this has, to a large extent, stymied the adoption of artificial intelligence widely in the health space. A big issue is the fact that artificial intelligence is dependent on claim data. Like I mentioned earlier, the whole concept is based on data. A large amount of data is used to train the algorithm. The challenge is that data needs to be of good quality. That data needs to be clean. So we go to the challenge of how clean is our data? What is the quality of the data? Like everybody has heard about computers and technology, garbage in, garbage out. Like I mentioned earlier, they're just the general trust issues. Am I sure this system is making the best decision? Am I sure the decision this system is making is informed with the right information? Finally, there's the issue of fear. There's a general mindset and fear. Finally, there's the issue of fear. There's a general mindset and fear by a number of people that machines will replace us, more so artificial intelligence. So for anybody who grew up watching the Terminator movies, Skynet is upon us. There's the fear that if we train these computers to do this, there's been the conversation, will computers replace doctors? I don't think it's likely, but then that's my view. But the fact is, these are some of the issues that stymie the adoption of artificial intelligence in health. So we've generally looked at what digital health is. We've looked at some domains of digital health or digital technologies in the health space. We've looked at challenges. We've looked at 3 digital health technologies that are used in the health space. Now, let us look forward. What can we expect over the next few years, next few months, and possibly next few decades? So, in my opinion, this slider will move a bit more to the right. It is becoming clear to all of us that the standard brick and mortar model of delivering healthcare is no more practical. It's not going to be the norm for a long time. We're going to move more and more to the right towards the use of digital technologies. If you think about it, the largest bookshop in the world does not warehouse any books. It's a technology platform. The largest transport company in the world does not own one car. How far is it? How far into the future is it before technology firms begin to own healthcare systems? M-Pesa in East Africa revolutionized financial inclusion. M-Pesa changed completely the way the financial landscape in East Africa is. At some point or the other, we are likely to come up with an M-Pesa for the health sector that relies largely on technology. And I am assured it will change the landscape in Nigeria and across Africa. But there are some technologies I expect over the next few months, few years, and possibly a few decades to have more and more adoption in the health space. Electronic medical records and electronic health records, telehealth, artificial intelligence, and mobile tools. Now, this could be mobile tools for wellness, mobile tools for health messaging, mobile tools for triaging, mobile tools for communication, to do all sorts of stuff. But a lot more healthcare would move to technology platforms. However, what do we need to happen for us to get there? We're going to have to encourage greater collaboration between health and technology. We're going to have to improve our regulatory landscape. We're going to have to build greater capacity in health workers to use data and digital tools. We're going to have to come up with greater amounts of and definitely cheaper funding. And we're going to depend more on our communities of practice, whether they're clinicians, digital health entrepreneurs, or informaticians. Ladies and gentlemen, I hope that has been as interesting for you as it was for me. I'm done. I'll take questions.
Well done, Shupo. Thank you so much. Very engaging and insightful presentation.